to get on. So welcome to our project scope today. Thank you everybody for joining. Just as you noticed, we are recording this session. It will be on our Canvas page for you to go back and access later. By staying on this call, you're giving us permission to have this recording. If you could take a minute and rename your profile, it just helps us know who's on the call, who we can reach out to. That's one of the key components of an ECHO, is building that community of practice and networking. So it also helps you guys know who to reach out to when you hear those amazing discussions. Raising your hand is at the bottom of the screen that you can raise your hand. We'll call on you. We can call on you. You can also put your information and comments or thoughts in chat is another great way to share your thoughts. Sometimes, or a lot of the times, we're talking about individuals and sometimes sensitive subjects. So please remember to avoid using any identifiable information. If you're unsure of what is identifiable, please reach out to a team member. We all have an asterisk by our name so that we are easy to locate. If you've never been to an ECHO session before, there's some key components of it. And like I mentioned, one of our big components of it is to build that professional networking, knowing who to reach out to, or just different colleagues throughout the state and the nation that are dealing with some of the same topics. So feel free to be interactive in this. We also have then a didactic speaker, and we'll do a case presentation and feedback at the end. The case presentation is a great way to gather information from the colleagues on the call. So if you ever have a case that you are just struggling with, or you want to share information with us, please consider to do that. They're a great way to learn and practice with each other. ECHO is an interactive community, so we're all really passionate about some of these topics and want to make sure that we're understanding what's going on in our community. Again, just those case studies. So if you're interested in doing that, please reach out to Project Scope at usu.edu, and Bailey will reach out and let you know when you're able to do a presentation. We do offer credit for attendance, so we will send out a survey. We'll also be dropping the survey in chat throughout the session. If you'll take a minute and complete that survey, it does give us information so we can go back to our funding source and be able to keep these sessions for free. Canvas is where we store all of our information, so we will store all of the recommendations that are provided about the case, the recording, as well as any handouts or things that are gathered during this session. There's also all of our past sessions on that Canvas page. So if you want access to the Canvas page, just again, reach out to Project Scope at usu.edu. We also have our social media, so our Facebook, Instagram, and LinkedIn pages that you can find valuable resources, information about upcoming sessions, and any other things that people share with us, so other webinars or useful information. Again, our next session will be in September, and I am going to stop talking and turn it over to our amazing speaker today, who is going to be talking to us about the heart extension at USU. So, Tim, I'm going to stop sharing and let you take it away.
Okay, very good. Well, thank you very much. I appreciate you letting me come and spend some time with you today. I'm hoping you're all seeing a screen that's appropriate.
Nope, we're seeing the other one. So if you go up to your display settings and switch it, it will show.
We keep switching. Let's try it again. We'll do it again.
Okay, that is working.
Well, it's always an exciting way to start, because on my computer system, somehow it's backwards. And so it switches back and forth on me every now and then. And that's always a challenge. It makes it more fun when we do these things. Okay, well, I'm glad to be with you today. Again, my name's Tim Keady. I'm part of the Heart Extension with USU. In our role, you see our titles, Health Extension, Advocacy, Research, and Teaching Initiative. It was originally a team. It was actually hired about 5 years ago to see if we could reduce deaths from substance misuse, specifically opioids, for the state of Utah. So that's been kind of an interesting way to be hired. And as you see here, there were actually 5 of us hired, and we had an evaluator that worked with us, Dr. Roscos, that worked with us and still works with us at times doing our evaluation and helping us to provide good, accurate data throughout our programming, throughout our years that we've been doing this. So we've actually had some really good experiences, opportunities to work with great people. We've had a few people come and go, obviously, as anybody would with any team. But I think the thing that's interesting to me, looking at kind of the makeup of our team, is that we are diverse. We've got a diverse group of people that work with us. And you'll see what the initiative was set up to do. Talk about joining community partners, helping our state become healthier is what we were designed and asked to do. Originally, we were on a 4-year contract, as this is our 5th year now. So obviously we've been a little bit longer than that, but about 2.5 years in, after we'd had some success with grant writing and doing some different things and working with the state, as well as even going across the nation, we were asked to stay longer and provided full-time positions if we would like. And so I originally was going to retire after those 4 years, but because of the opportunities we had, and because of the ability to reach some different groups, I decided to stay a little bit longer. So I'm obviously still here. And we have people that really have done some amazing work. We work on, obviously, grants is what we do, writing grants, receiving them, providing deliverables in different areas, and see some of that as we go through. But I think the success we had, I think for the first couple of years, somewhere around $8 to $9 million in grants were brought in that time frame. Some of them for extended period grants, some for some year-long grants, but we're able to be pretty successful. And you'll see as we go through this, some of the financing that we've had and funding that we've brought in. But the reality is we have unique academic resources based on the people we have hired. You see we have a couple of PhDs. We have a clinical psychologist who's part of our team. We have a young woman with actually 2 PhDs in education and research, as well as master's level, and people with different experiences that we wanted to bring in and see if we could help our team and help our communities grow as we've begun doing this process. You'll see unique academic resources. We work with existing coalitions, and we establish even community partnerships. We engage key stakeholders in both rural and urban settings with some of our programming done specifically for those areas that are really hardest hit by substance misuse, mental health concerns, all those areas. So Southern Utah, as well as the Davis County areas, Salt Lake City, all those areas that are experiencing difficulties. And working with stakeholders, as I'm sure all of you do, we try and facilitate investment in national, locally identified needs and concerns. And the biggest thing for us is providing that evidence-based information and research to the community. We can say a lot of really cool things. It looks great, sounds fun, but we really need to have it backed up by research. And we do research ourselves, as well as looking at other research that's being done, especially in substance misuse, as well as suicide. For the Heart Initiative, just to give you a little more background, we have 4 pillars that we work under, essentially, prevention and education, community ties, strengthening, stigma and harm reduction, and resilience building. And you'll see some of those pillars as we go through this little presentation. Before our presentation, I thought that'd be kind of an interesting way to do it. And as we go through this process, I have a little note that I did as I've actually just recently injured my hip. So I've got a torn labrum in my hip that I need to have surgery on probably in a couple of weeks or so. But it was interesting as I was trying to recover and told not to move and doing some things and staying at home for a little bit, working from home, I had some thoughts from under my pergola. And I thought, well, what am I going to talk about when I meet with a bunch of other professionals about substance misuse, as well as working with youth and children, and what can we talk about there? So I thought I'm going to show you some different ideas of things that we're doing and done, and then actually go through a program that we have that talks about youth and fentanyl and what we're doing with that going forward. Because we obviously have programming that we do across the board, trying to help our communities based on what our communities may be in need of. We'll do an assessment of our community, see what is necessary, and maybe most pressing in that community based on a number of different needs, and then kind of direct our research, teaching and training to those areas, and bringing in people to help us, bringing people across the state as well as national people to come and talk to us about what we can do better in those different regions and areas. And so I'm going to show you some different programming stuff that we've done and things that we've brought in to our community, specifically in Cache, but also across the state, to try and help be more effective as a group. So examples, one of the things we do, this is a program we did, how multidisciplinary public health teams can impact the opioid crisis. We did that for a presentation of other public health workers across the state and then across the nation at some regional programs that we were asked to present at. But we really talk about being multidisciplinary in all our areas and what can we do to be effective and how can we make that work for us. And some of the fun things that we do, obviously you'll see here, we went and actually created this kind of fun way to look at what we're doing with the opioid crisis in Utah, into some of these areas. So, again, we have the 4 pillars, talked about those. Actually, were created at a program that we did with a group of other people across the states and across the nation, deciding what we could do to make it better. And so I just kind of thought it's kind of fun to see some of the things that we looked at from the beginning to learn what we could do better with our state. We talk about impacts over approximately 3 years. This is some of the things we had from our beginning. So approximately a year and a half ago, this was created, looking at some of the impacts we've had, future articles. Again, this contains some of the information that was there and what we've done. But one of the things that we talk about quite often, for example, is I get asked, Narcan kits, how many we distributed, how many have we helped, or how many have helped save people in communities across the state or across the nation. And that's something that I'm sure a lot of providers, we don't disclose that information. I spent about 30 years in EMS as part of my background in training in exercise science and health counseling. And it was always fascinating to me that people would talk to me about what we had done, what we were doing, looking at some of these slides, for example, saying we've done articles, you've done websites, you've done programs, you've done funding, but how many lives have you saved? And I'm just like, well, that's something that's part of what we do. That's not the main focus on what we do. And I still get questions, and people will still get frustrated when I don't ask or answer them and tell them how many lives we've saved based on the number of kits that we provided. I approximately know how many lives we've saved, but it's not something I feel is appropriate to disclose. I even get asked by our groups to disclose it. As far as our groups, I should say that the university will ask me to disclose for articles and for things of that nature. And I just say that this is not appropriate to do that from my clinical background and what I have done in the past, not something that I think is appropriate. I probably should say that I was 30 years in EMS. I actually spent almost 18 years as the associate director of a student health center back east. And also my impact for that university was I worked with the students that no one else wanted to speak with. So if someone else did not want to talk to them about their medical issues, they were brought to me. If someone didn't want to talk to them about their mental health issues, they were brought to me. If they were worried about their eating, they were brought to me. So as an administrator, I got asked to do lots of different things that were not really supposed to be part of my job, but because of my background, I was able to help and assist in areas that made us be more effective and efficient as a student health center. So being part of crash teams, being part of all of that throughout many years, and being on call for about 17 and a half years, 24/7 days a week, did become a little bit tiring after a while. But I really enjoyed it. It was really something that was really exciting for me to do. I learned a lot, worked with lots of people with eating disorders, down to people that just didn't know what to do with their rooms. How do you make their rooms be a better place and more efficient for someone who has a disability? So again, lots of areas that I worked with that became important. Okay, you'll see some more grant funding presentations. We're going to provide this to you. If you'd like to get a copy of this, it will be available for people to get one. But again, just more information about what we've done. This is where our locations are for our faculty, the approximately 9 counties that we serve, as well as across the state. When we were first hired, they brought us into the areas they thought were going to be the biggest issues, where we could have the most effect. And we've pretty much done that. Things worked out pretty well. And Ken White, Dr. Ken White was actually the person who decided how this would all work. It was really fascinating to work with him and be able to have a team that's done very well for our state as well as for our nation. You'll see some of the things that we do as far as events go. I just wanted to include some of this so you'd have, again, an idea of what we do. We provide community events. We do recovery events. Recovery Month will be in September. So we'll do things across the state as an extension group, as well as a team, as well as our all the different groups we're working with. And then we have a Late to Remember. It's going to come up at the end of August. We're going to have it actually here in Logan. We'll have it at the Cache County Event Center, kind of behind the fairgrounds. And the idea there is just a remembrance of people that have been lost to substance misuse and overdose, as well as suicide. We include that also in what we do. And the theme for some of the things we do, obviously, are join the Voices for Recovery. Together we are stronger. That's for Recovery Month. So we do a lot of things in our community to hopefully make it stronger and provide opportunities for people to meet together and then discuss what's going on in our communities and whatever impacts they can have. We have a Rural Opioid and Stimulant Wellness Summit coming up in October. We'd invite providers to come to that also. It is for providers as well as for people in the community. That's something we'll be doing. We're going to have an equestrian rides, different things will be going on there down in Price. So it'll be very exciting. We've done these for the past 5 years and been very effective and have between 250 and 350 people attend. So they're very well attended. And if you're interested, let me know afterwards and we can get you more information, or you can look up our website to get that information also. Naloxone training, something else we do consistently, kind of across the year. And again, just for, I guess, for your information, these are things that we do consistently. And you may ask why, when we talk about children, we're talking about naloxone trainings. Well, I've trained young men and young women and family members down into 10, 11 years old, how to use Narcan. Some with their parents and some with groups that ask us to train the children because their parents have agreed to that. And we've done that consistently. And at one point, I worked with Indian Health Services and was asked, as a presentation we were doing down in southern Utah, I was asked, why are we doing this training to the youth? Especially we had preschoolers coming through, and it was a kind of a field day that was done at Four Corners. And they're asking us, why are we doing this to the youth? Why are we talking to the youth about Narcan, naloxone, substances, all of that? And I sat down with a nurse from Indian Health Services, and I said, what do you think about what we're doing? And she said, let's see how it goes. We'll just provide information, and then we'll kind of change up our presentation as it goes to be more specific or less specific, and do it for the appropriate level of education that children may have, and we'll go from there. Well, our first presentation that we did, we had a young girl tell us, oh, by the way, yeah, this is really nice. My mommy puts her drugs away when her boyfriend comes over. And we went, okay, we'll maybe talk to you a little bit later. Thanks for that. And then we kept going through the process, and we had another, remember, these were preschool 4-year-olds, 4 and 5-year-olds telling us these things. And someone else mentioned that, I've seen this before. I've seen that, I've seen places like this happen before. We do things, we get sent, we call the ambulance, we call the fire trucks. This is something that happens, quite often in our community. Right down to where we trained another group that came through. We trained a whole group of students throughout the day, and we had a group that came through with 5th and 6th graders. Actually, 5th grade was the highest, it was 4th and 5th grade. And a young man said, oh yeah, I know about naloxone and Narcan. Yeah, I've used it before. I've seen it. I know how it works. Oh, by the way, yeah, I know how to pump a stomach. And we obviously from that point on began really talking about what the substances were. And we could look at different types of medications. We had some posters showing medications that were real and fake, and candies versus real medications. And we had children, again, kindergarten, 1st grade children pointing out which were real and which were fake 100% of the time, knowing what was really correct and not correct. So we learned from that point on, we don't discount what we teach our children. We really ask to see what they'd like to learn, and obviously make it to their level educationally and developmentally, try and be appropriate that we can. But in most cases, the young children we worked with knew more than we expected about substance misuse, as well as suicide, as well as naloxone and Narcan use. So again, something that we learned very quickly was not to think that our children won't understand what we're talking about. Some other things we just wanted to show you real quick as we're going through this is talking about some of the community participation that we have as a group and as an organization. You'll see me in the back here in the hat. It's part of our mental health and suicide prevention walk that we had here in Cache County. Almost all of our groups and all of our people we work with in our initiative participate in community activities. I'm also part of the Live On group. I do some work with them as far as their research goes. So just showing they're kind of well-rounded. I also am part of the WAB, the William A. Bernard Warming Center. I participate in that. I actually was one of the people who just wanted to do it a couple days a week, maybe. Ended up was asked to help with the on-site group, and then ended up being the person working on site for about 3 months, being on call again for most of our evenings, helping our unserved and unhoused population. So it was really very amazing what we did with that group. And as part of extension, we are allowed to participate in things that we think are important for our community, and finding a place for our unhoused people. And it was very, very cold outside became very important to us and to me. And so it worked out really well. So we were able to help a lot of individuals. And we had over 118 volunteers. And some of you on this call, if you're from this area, may have volunteered with us as part of that group. So pretty amazing group, pretty amazing people to work with, as well as we called the guests that came to see us, that participated with us. Very rewarding. And the reason I even put that on here is because we had children who actually came to see us and were unhoused. Many of them living in vehicles or had just lost their housing with their families, removed from their current situation, or for domestic violence issues. So again, families participating in something we didn't expect, as well as substance misuse and mental health concerns. So a significant level of mental health issues in that population, obviously unhoused. And somewhere around 100 people participated in that group, came to see us and spent a night with us. And of that group, somewhere around 95% of them were from our Cache County, not from anywhere else, but we're actually from here. So a pretty amazing group of people to work with as far as guests and people who volunteer. And again, just some other presentations we do, resiliency presentations to county employees. I was asked to do a presentation or presentations, 6-session presentation for helping children achieve independence, and an ergonomics and exercise for Cache County employees again. And we even have book clubs for some graphic novels we helped create as part of a grant for people to look at and use, and actually been well received across the country, and some cool stuff that we do. So people who've experienced substance misuse, mental health concerns, were actually invited to write their stories. Then we had someone who was artistic and actually helped draw those stories out for them. So kind of cool things that we do. And then kind of recovery community videos. We have somebody that we asked to speak to that, so what they did, what they went through, and what they would recommend to others in the community to get treatment. Key terms, again, we talk about substance use disorders, person in recovery, recovery communities, substance use treatment facilities, harm reduction, stigma, medication for opioid use disorders. Again, simple things that we do. Stigma reduction, we work with that, talking about various ways to reduce stigma. And again, terminology for us becomes very important. Person first languages. And again, I'm probably talking to the people who know all these things, but just again, to show you kind of the areas that we look at and find important in our work, kind of throughout the state. Pretty interesting to see how someone describes themselves initially, and then after treatment or after going through, we have a harm reduction series that we do with people in treatment. They begin to start talking about themselves as a person with a substance use disorder or a person in recovery. That's really kind of an amazing process to see them go through that and see what we happen, and see how we are able to help them think more highly of themselves and give them some of that self-esteem. One of the things we talk about is why do we do all these things? Because we've had, the highest level of overdoses reported. This is from the 2022, and it was 104,000 people died of overdose, somewhere around 70% related to an opioid, as well as other substances. Stimulants, of course, are still there. Cocaine, still there. Heroin, all those things are still there. All the things we see are there. The thing that's changed is adding fentanyl and all those other derivatives of that substance being made by people all over the world. So just something else for people to look at. I talk about naloxone, so I put this in here just telling you that this is how naloxone works. We're worried about a substance being misused, especially an opioid, whether it's synthetic, whatever. It causes death because it actually causes people not to be able to breathe. Respiratory depression is caused by the opioids taking over the receptors on the brain that cause people to be able to breathe. And then you'll see this little square is the naloxone that's actually attached to those receptors and allows people to breathe for a period of time until it gets knocked off again by that substance. So kind of a really quick way to look at that. And we find this really helps people to visualize what's going on with them and also with their patients or people they're working with. So the people that can't breathe and die of respiratory arrest are generally someone who has an opioid somewhere, whether I don't care if it's cocaine, whether it's stimulant, whatever it might be, there's something causing what's happening. And generally the opioid is what's doing that if they can't breathe. Steps for responding to overdoses. We talk about all of that. I'm sure all of you have seen these before. Again, we do lots of naloxone Narcan training. We talk about Good Samaritan laws. That becomes important for many people. So we do have people still that are dying because people walk away. People actually leave that person to die because they're afraid. We want people to realize they can make a phone call and get assistance if they want to. And I've seen this even back east at the university I worked at. We used to call them drive-bys. We have a volunteer ambulance agency below our student health center that was manned most of the time, but not 24/7. And students would drop family, friends, people off there if they were unresponsive and hope that somebody saved them in time. So we have seen this for a lot of years, anything unusual. Now getting back to more of the stuff that we're going to talk about with the youth. There's a Strengthening Families program that we do. And you'll see that was been done for about 3 years. Had approximately 80 families attend. That's only in one county. We've done this across Utah. We've probably had to this point somewhere almost close to 200 families have participated with us in those 3 years. We've done online sessions, we've done in person, through COVID, all the different things we did, working with Extension, as well as even the Bear River Health Department, as well as some other coalitions that work with us. Again, so it's a Strengthening Families program for youth and parents between 10 and 14 years old. Really effective program, evidence-based, it's done really well. One of the examples, just of the kind of the topics, you'll see love and limits, all these things. Again, the reality is, for me, the topics were well done, it worked out pretty well. But the most important thing was having families sit down and be together for that period of time. It's a 2-hour session, about 2.5 hours, adding a dinner. We have a dinner first, we have 2 sessions, separate for adults and the youth. And we bring the youth and adults together for the final hour and have them experience something that's very different, usually something pretty mobile, pretty moving around, doing something that's fun, but getting them to communicate more with their families becomes very important. An example, we have them create family shields. We talk about with the youth, is it easy being an adult and hard being an adult? All those things, we can show them some of those differences and maybe get them to think a little differently about their parents and what they're going through. So for us, it was really cool to see that happen. And because we had many counselors that were part of our group as far as the facilitators, we had counselors tell us that there were family members that they'd been working with and seen from the time they were very young, 1st or 2nd grade, so they were in 6th or 7th grade. They'd never seen them speak to their parents until they saw them at this program, about 6 sessions in generally. So it was pretty effective, worked pretty well. I think we have some really good ones at Utah State we can use, but this is something that was funded through a grant that we had, and then the Department of Health will fund it because it's one of their programs that's allowed to be funded by the state. So kind of a cool thing, worked out really well for us, worked out pretty well. Monitoring the future survey, again, talk what's going on with the youth, what's going on with the people we work with, and who you see quite often. We work with a lot of the very young people and young youth, but our future survey is basically for the 8th, 10th, and 12th graders. Talks about the reporting of illicit substance misuse and drug use. And I think it was kind of cool that this is still going on. I don't know if I always believe the numbers that we get, but we can only do the best we can. Again, cannabis use, alcohol use, all of these they thought remain stable. Use of narcotics increased slightly. And then marijuana, of course, generally is continuing to grow, especially as we legalize it. But that's just something that goes on. Again, just for data for people to look at later if you'd like. This is something that we had a group of youth in our 4-H program wanted to do something about opioids. So they came up with this. Opioids are a big yikes. Something they thought was pretty cool that they would look at. And then they started going through that process of creating it. So it's kind of cool that they did that on their own and came up with these. And we've got a whole group of posters that we use with other youth as we're talking about opioids and other substances. Okay, so finally, we get to the Understanding Fentanyl program, which we're going to talk about that really was part of that. Again, I wanted to go over and show you some of the things that we do as a group and just go through this program that we have just kind of quickly to show you what we do when we talk about training parents of youth and even some of our teachers if they'd like to participate in that. We talk about opioids and fentanyl, signs of use and overdose consequences, how to respond, trends from the National Youth Risk Behavior Surveys, do's and don'ts of addressing and preventing substance use and misuse, utilizing evidence-based prevention strategies and campaigns, toolkits, and other resources for school professionals they can use. One of the things we do when we always talk about these things is we talk about there's difficult subjects. We do have people that do have post-traumatic stress. We have people that have adverse childhood experiences. We know all these things that can occur with groups of people. So we do, as I'm sure all of you do, talk about what we can do to make sure that people feel safe. And if they don't want to participate, they don't have to. So we do provide that to you. The slides depict images and discussions of illicit and prescription opioids, signs of overdose and steps for response. If you find any images and discussions uncomfortable, feel free to excuse yourself at any time by stepping away, closing your browser, or muting your screen. So again, something we just go over with everybody as we do this. Then we start talking about what are opioids, go through the opioid information, talk about, they're used to relieve pain as a prescription, but also there are some illicit substances out there, bind receptors in the brain that respond to opioids. Again, that's why we showed you that information before. Then go over prescription painkillers, illicit drugs. What are people doing? What's common? What's uncommon? In our communities, a lot of people prescribe the oxys and hydrocodones, but we're seeing much less now that Intermountain Healthcare decided to reduce their prescribing, and it worked really well, actually. They dropped their prescribing at one point by 60% in their first year, I believe, and then it continues to drop now. And people that do need prescription painkillers, especially the oxys and things, have pain clinics that they can go to and get that information with a diagnosis that allows for that. So we go through this with our groups. I'm talking about illicit drugs, prescription painkillers. Then begin talking about illicitly manufactured fentanyl. What is it? So we'll talk about it's a synthetic opioid, an analog of pharmaceutical fentanyl, 50 times more potent than heroin, comes in liquid or powder form, standalone, mixed with other substances. Carfentanil is most common form in current supplies. It shows you what they look like. Now, one of the things that working with people in treatment, I've had people in treatment that actually their drug that they dealt was fentanyl, and had to interject at times with someone who's talking about how cool it was, you know, they were able to do this fentanyl. And in the end, the reality was this person was going to jail, federal prison, for a very long time. And they came in between. I don't know how they got out, I don't know what went on, but they were allowed to come out and go through treatment for a while, and then went back for their final sentencing. But the fascinating part of the whole thing was this person, you know, always talks about how great it was, how he liked being a dealer of drugs and this, and finally, you know, somebody asked him, well, how many people did you kill? And he just looked at us and said, it's not my problem. And people were, even in treatment, said, well, that's not really a good response. Did you feel bad if somebody died? And he said, they're stupid enough to use it and buy it from me, he goes, I'm going to make money and sell it to them. And it was really interesting the way that even the group responded in kind of a negative way. And of course, the person did not like that. So they kind of made a joke and kind of said, well, you know, everybody's going to die at some point or whatever. And kind of joked about how his, you know, his drug was better than everybody else's still. And I called him on it. And of course, a very big person kind of rushed at me. And I said, look, dude, you don't want to go here. Go sit down. You need to just relax, talk about what happened here. This is not something that's going to help you going forward, is it? And it was really interesting, you know, such a big person, you see this person coming at you, and but really, he was really ashamed of what he did. He really felt badly about what had happened, but he couldn't express that to anybody. He had a difficult time doing that. So we tried to encourage him afterwards. He came and apologized, and you know, we encouraged him, you got to really change what you're doing, change your thought process, and really think about what really happened. He said he wasn't allowed to do that, because if he did, he wouldn't want to live either. So again, we work with all these different groups of people that will provide us with information that could be helpful going forward. So again, we're talking about giving this information to teachers, those that have youth, people that may want to know what it looks like. What does fentanyl look like? What does it look like now? The reality is, if I were to show you a fentanyl tablet pressed into an aspirin tablet, you would know the difference. In fact, the fentanyl tablet would look better than the aspirin tablet. We've actually seen those. It's not something you want to do, something you want to see or find, but the reality of it is, comparing something that's even prescription medication to something that's on the street, the product coming off the street looks actually cleaner and better when you're talking about impressions to identify it. So really not a good thing. So we encourage everyone not to use any drugs off the street, not to buy anything, because remember, it's a dangerous substance. You can't see it, you can't taste it, you can't smell it. You don't know where it is, you don't know what you've got. And we see so many things happening to our youth that we really are surprised at times that they think they're getting an Adderall pill, for example, and it's essentially straight fentanyl. And then they're dying of it because they're opioid naive, they've never had it before, their tolerance is not there. And so we have, in most cases, we have less people using drugs, but more people are dying because of what's in it with the fentanyl, those different analogs. So dangerous amounts, obviously, very small amounts can kill people. Doesn't show up on tox screens generally if you're looking for it. The tolerance is different. Lethal dose of fentanyl is seen here. But again, we don't know what's in our pills that we're getting if you buy them off the street. And for children, sharing things and doing stuff, we never know what's going to happen. I've even been told when I was coming back here and deciding whether I wanted to take a position, doing the HEART initiative and HEART team that we were initially, I went to a place in another county, and I was told by someone that, you know, my brother, who just graduated from high school, said people used to come to school, they would put a bowl out, they would all put drugs in there. pharmaceutical drugs, generally something from prescription medication they've gotten from their parents or someone, they put into a bowl, and then they would all take one before their first class. Then they report back and see how they were feeling. Not telling, nobody knew what they were taking, didn't care, something happened. Now, this is in a school not too far from here. It happened consistently. Only 2 to 3 years ago that we know of exactly what was happening 2 to 3 years ago. We know it's still occurring now in a high school. So things happen. Our middle school, lots of problems there. We have a lot of vaping going on. Obviously, cannabis with vaping, very difficult. So a lot of things are happening. So getting back to the fentanyl, as you can tell, I get kind of sidelined at times because of what we see, what I do. But the effects of opioids on your body, signs and symptoms, obviously reduces pains, regulates pain perception, slows down the CNS. For some people, it provides euphoria. Not everyone gets that euphoria, but decrease or stop breathing and an overdose. So see, we try and show people information that it's easy to understand and provide that for them. Talk about recognizing an overdose, especially an opioid overdose, to not responding, slow to stop breathing, gurgling or choking sounds, the nail beds, cyanosis, blue, purple lips and nails, cold and clammy skin, small pinpoint pupils, those types of things. Also looking for paraphernalia around them, seeing what they find, making sure that you're safe first before you begin trying to provide care. And then we have the steps to respond to an overdose, evaluate for signs of overdose, call 911. Generally, we call 911 right away anyway, and then administer naloxone. If no response, continue to do that. Training people on. So obviously, we train people very differently than this, but those are kind of the basic things that we want people to understand and know about responding to an overdose. You'll see this is kind of the way that naloxone is administered, either IM, so into the muscle. There's the atomizer, no longer used generally. They may be at times, but not often outside of a hospital or provider. And nasal spray Narcan, which is what we do and use mostly for our patients that we work with. So again, responding to the overdose, providing chest compressions, CPR, and put recovery position if you have to leave. The biggest thing we want people to understand is that calling 911, getting that response started becomes important. We want to provide some period of time for providers to get there from EMS or fire or wherever it might be. Police departments carry and administer naloxone. Actually, I provide naloxone to some of our police departments, some of our areas around here also. So they do have it. We have it in libraries and different groups. If they'll accept it from us, we'll provide it to whoever would like it. It's something I do across the state as well as in our community. Recovery position, again, putting people, how do you put someone in the recovery position? And if we're doing this in person with groups of students or with teachers, whoever it might be, would actually show them how to put somebody in recovery position. In case they've never tried that, if they've never had CPR or done anything like that. What if Narcan doesn't work? There's lots of reasons why that may happen. We've got xylazine coming out because of this is, again, a large animal tranquilizer that people are mixing with the opioids, so it really becomes difficult to revive someone. But CPR is something that still can save someone, even if they have a significant overdose. We've had patients and people we worked with who've actually kept people alive for 20 to 30 minutes doing CPR. Of course, they're very, very tired, but save someone's life still doing CPR to keep them alive. So again, naloxone, Narcan is great if you have it. If you don't, try and do the best you can with CPR. Some current trends among youth. We go through the survey. We talk about some of the things that have happened, who's ever used prescription opioids, and then who's used it in the past 30 days, showing people what that looks like from a practical standpoint. We do see those groups of people that use it at a higher level. So female students, LGBTQ plus students, same-sex partners reported higher use among all substances. So we wanted to make sure that we look at and target those groups to help them if we can, provide good information. You see again, high school students who drink alcohol. So we see trends we're seeing when they're measured, so they're going down. But again, we never know if that's really always correct. So we do use the information and the data, but we try and make sure we're looking at it even from a different perspective in our own communities. Make sure we're getting the correct information. Where do youth get fentanyl, for example? Social media, advertising it. Just like DoorDash, people will deliver it to your home and drop it off. So it's pretty amazing what really can be done with all substances now. And generally, someone who wants something brought to them is trying to get something like Adderall or something else that they think is going to help them in school, for example. And many times it will be straight fentanyl. So we encourage people not to do that. We encourage our youth and our teachers and people to remind them of that and just provide them good information.
Tim, can I ask a quick question?
Yes.
On that second bullet point right there, it says avoid sites that offer sales with prescription.
Correct. Because the
Really?
youth don't go to those sites. That's what they're really saying.
Okay.
That's something our youth don't do. Yeah.
Okay, perfect.
And there are some, remember, there's some adults that will buy things off those sites, and then the youth will get them after that because it's something they think is okay. And in Utah specifically, we find that everyone shouldn't generalize that big, but people in Utah are more likely to misuse a substance if they believe it's from a prescription. So anything they think has been given to them by a physician, they're more likely to misuse that if they're able. Does that help a little bit? And then we talk about addressing preventing substance use in the classrooms and schools, kind of do's and don'ts. Same thing I'm sure you work with your groups. The don'ts: don't exaggerate, scare tactics don't work, fear-based events or assemblies, don't rely on knowledge-based interventions, try and keep morality out of it if you can, and don't group at-risk youth together. That becomes important also, because we do see that cause significant problems in the groups, especially some of the groups we work with down in southern Utah. There's not a lot of choices. You have to be very careful. And the do's: understand these stages, risk childhood experiences and positive childhood experiences, integrate them, encourage question, discussion, be honest and direct, teach self-competence, social competence, strengths, normalize behaviors that are positive, and then creative campaigns. Do some things to help them be more positive and have good self-esteem. And one of the things that we run into a lot too is talking about sexual health in Utah and the substance misuse. We see that sometimes those go hand in hand at times. More risky behaviors occur. We just want people to be aware that good education helps in all areas if we can. And I do have when I send this out, this will be active for you. But social emotional learning is talking about how important that may be for some of our groups and how positive that can be. And then what's the role of schools, school leaders, all those things. This is a presentation we developed for teachers, national group of teachers, to do that for us, to provide good information to them. So some of the things we have here, we have resources for professionals, tools that work and don't work, kind of the identifying counterfeits, 6 to 7 drugs that are on the street, 6 to 7 pills are going to be contaminated with fentanyl. So think of people using drugs on the street, 6 or 7 of what they get out of 10 will contain fentanyl and should possibly cause an overdose and death. There's awareness. Here's some resources we have: the PTTC Prevention Technology Transfer Center Network, and then regional resources for professionals, Utah professionals, and our information. So sorry to go through that, but you'll have the opportunity to see that if you like at some point. And so what questions do we have that I may answer quickly?
Tim, this is Kurt again. I actually do have a question. I just saw in the news in the last couple of days in Washington State that they have a policy that no longer requires them to identify drug-exposed children or drug-exposed babies, that they can still receive services without a report. Just wanted to get your take on that. I'll throw the article. It's out of Seattle Times, I think, but love to hear your take on that policy change and what you think it might do for some of those babies there that are going out of the hospital without a report and may or may not receive services based on family dynamics and family choice.
Yeah, that's really dangerous. I mean, I understand the process of what they're trying to do, right? To get rid of some of that stigma and bias of people that they hope will ask for care. But it's difficult because remember, we've got people who, if you're misusing a substance, in most cases, I work with people that live on the street that, live in bathrooms, right? We have families that live in a car or live under a tree or whatever it might be, because of that substance misuse. And now you've got somebody with neonatal syndrome going in, having problems and not being treated and not having to follow up. That's a problem. In Utah, I know Division of Child Services and stuff will go and interdict for people that are having problems and try and help. Some people think it's really punitive, but we see many lives are saved that way. And working with people even in Utah, in the middle school I work a lot with in Brigham City, 70 to 80 students are seen by someone from Child and Human Services for counseling every day. Huge number. For me, it's a huge number of children that have been affected by that. So now you do something like that in Washington State, where that's being done, and you're taking out that ability to care for those youth and for those children. We're talking, that becomes a problem because many of those people, if they don't have to, will not get care for their children. And so the children who are born go through obviously terrible withdrawals, terrible sickness that can kill them. Just that withdrawal has that possibility of killing, especially a small child. If you've got adults that are sick for 2 to 3 weeks, they can't eat, can't walk, can't do anything. That's pretty difficult for a child to go through. So no, that's not something I'd be very happy to see at all.
Yeah, I'm glad my thought process is in line with you. I've worked early intervention my whole life and see these little kids that get services and still struggle. And I mean, this just, in my opinion, it opens it up. Obviously, trying to get rid of the stigma, I get that, but I just thought there's got to be better ways to do that than just to say, we'll report if you want us to report. If you don't, you can still get the services. But it just seemed like those kids who really don't have a voice at that age kind of get left in the dark. So anyways, I just was curious if you'd seen that, if that was something that, since you have so much information on lifespan issues, not just with little kids, but what the look is down the road if these kids don't get services. And I think we all know that the services earlier are better. And so I just want to get your take on it. Thanks for your
Thanks.
sharing.
I guess one of the last things I would say is that I believe everyone has the right to get services and to get treatment and get care. But again, we have to be willing to pay for that. Someone has to pay for those people to get that care. And that's something I think is becoming difficult to, I guess, to have everyone have the same ideas of how it will work. It's a huge cost, having drug and alcohol use and misuse. Huge numbers of people, somewhere less than 10% of the people who need treatment get it. I'm not even, alcohol. When I first began, even in Utah, most of the people we dealt with were people that had substance misuse things, but their choices were things like, heroin, cocaine, meth, that type of thing. Now the huge numbers, their major drug is alcohol. So that's what's the kind of a switch been to me. It's gone switched back, goes back and forth. And right now we're in the high levels of alcohol in a lot of our communities. Not saying there's not a lot of other substances going on too, but alcohol really is what causes many of our people to seek treatment. And again, just like having children have to do something, or parents have to do something with their children because of what's found, we find that people who get DUIs or DWIs, they have to get treatment because they're sent to do it. They wouldn't do it on their own. And many of them know that they would be dead if it wasn't because of that. So thanks all of you. And any other question, I don't think we're out of time, but I appreciate you all being here, and hopefully you've gotten something good from this. And I appreciate your department asking me to come and do this, and having Ms. Preston there, I appreciate her also.
Well, thank you so much. That was just great information and a presentation. I think it really hit home for me, the importance of navigating it from a whole family system, that it doesn't just impact the one person, it impacts our whole community and our family. So I appreciate you sharing this with us.
Thank you very much.
And so we are going to now go over our case presentation. So if you need to jump off, you are free to, but we'd love to have you, if you can, stay on. Bailey is going to go over our case for this week.
Actually, I'd love to stay, but I actually have group right now.
Well, thank you.
We usually had someone else to fill in, but we weren't able to get them set up in time. So I apologize, but thank you guys. I'd love to join another time. It'd be really great to hear some of what you guys are working with and doing. And I appreciate all of you very much.
Great. Thank you so much, Bailey.
Hey, let me. Can you see that? It looks right. Okay. Okay. Hi, my name is Bailey. I'm actually not an early interventionist or anything. I'm the echo assistant. But we had a provider send this case in, and so I'm just going to present for them. So a little background on the case. This is a 2-year-old boy who was born after being exposed to substances in utero, including, all of you are blocking my screen. Anyways, in utero, including fentanyl, heroin, meth, THC, tobacco, Vicodin, I don't know if that's how you say it, Xanax, and Adderall. The birth father also abused substances, and he died shortly after the child was born. When this little boy was born, he spent 2 weeks in the NICU without treatment, and after about 2 weeks, he was treated with methadone. And when discharged, the child would sleep about 15 minutes at a time and was extremely sensitive to sensory input. His original diagnosis was NAS and torticollis, and he lives with his adoptive parents and had tremors for about a month after he was born, and he also had excessive startle reflex. The family and provider's primary area of concern is that the child experiences frequent falling, and he seems unable to see obstacles in his path. And he seeks proprioceptive. I hope I'm saying all these words right. If I'm not, don't judge me. But he seeks proprioceptive input by pushing furniture, hitting, throwing, rocking, and he'll only push objects. He also bites and pulls hair, and he has a expressive language delay, and so he just uses a few signs, shakes his head yes or no, points, and can follow simple directions, but he does not use any words yet. He's also below the first percentile for height and less than 60% for weight, and the ophthalmologist saw no concerns when he did his evaluation. And so some of the goals and barriers, the main goals are obtaining age-appropriate speech, so speech that's appropriate for a 2-year-old, effectively meeting sensory needs throughout the day, and walking without falling. And some of the main barriers that they see are the child's sensory needs are difficult to determine and meet, and they're not sure how his vision, vestibular, and motor skills affect his balance, and he also does very poorly in a visually busy environment. But some of the strengths he has is he has great family support and compliance, and he has a 3.5-year-old adoptive brother who also has had NAS, and he made really good progress. And so that's the strength that his adoptive parents have experienced NAS and have been through this before, so they kind of are prepared and know about it and what they need to do. So these are some of the strategies that have been tried. The parents were instructed to help the patient accommodate his sensitivity to sensory input, but they felt like this wasn't effective. They've tried things like a compression vest, weighted ball, and bean bags, as well as brushing, infant massage, and joint compression. And they've also tried balance activities, proprioceptive strategies, such as rocking, swinging, getting pulled on a blanket, stuff like that. Mom has also decreased visual clutter around the house and in the places they go to help with that. And then they've recently discovered that being in a small enclosed space helps him calm down. So these are the three questions that they have. The first is any strategies, suggestions, tools, and resources to help child obtain age-appropriate speech. How to effectively meet the child's sensory needs throughout the day, and how we can help the child walk without falling and improve that skill. So, yep, that's it.
Okay, so we are going to break into 2 breakout groups, and we'll put those questions in all of them. You can even either as a group target all 3 questions, just pick one strategy. If you'll take a minute and turn your cameras on and do some introductions so we can all continue to know and learn about each other. Please don't jump off. It's great to get your input and suggestions from that. So Bailey, you want to go ahead and put us in that group?
Before we switch, could I ask, did he have his hearing tested?
He did pass his newborn hearing screening. So
But he hasn't had it since.
No.
Oh, okay, because fluid in the ears could cause that equilibrium issue. Balance coordination, I've seen it in a lot of kiddos. Okay,
Well,
thank you.
Yeah, great suggestion. So if everybody, so Kurt and Natalie, from your breakout groups, do you want to give at least one idea that was shared in yours? We'll start with Kurt since he's off mute.
No, start with Natalie, because I just put mine on my desktop. I've got to pull them back off, so.
And Natalie's on mute.
No, I honestly think that my note just disappeared. Like when I changed to the Loom, it's like your note's not available. So anyway, okay. By the way, oh, you had Kurt. Did you also have a Pat? I'm like, no fair. They gave all the PTs over
That
to
wasn't with me.
Okay, well, she must have left us. Some things that our group came up with. You said just one thing. I don't know. They had some. We had our EI friends from St. George that were in my group, and they had some great ideas about like figuring out how we talked about decluttering the environment, but like, what does this child specifically need? Does it need to be noise free? Does it need to be like an empty room? Does it need to only have soft things? Like maybe try to specifically identify how he best could, respond to speech therapy. And then also the recommendation of doing occupational therapy or, a sensory diet prior to any of the learning. And then I know you said one thing, but the medical person in me also wants to throw in, are we missing another diagnosis? There are some red flags here that I see for autism. I've not seen his developmental testing, so I don't know. And it also wouldn't be a magic answer if we knew that he had that. But I wonder if that's maybe why he's not making the progress that his older brother did. Maybe there's something in addition to the NAS. I'll stop talking and
Those
try
are
to find that
great
note.
suggestions, Natalie. So try to find your notes so we can put those on Canvas. That's awesome. Kurt.
So, yeah, oh, sorry, Bailey, I sent the notes to the Scope website, not to you. Sorry about that. There's a couple really good ones. They had a newborn hearing, but there wasn't any record of him having another hearing test. Just wondered if maybe there's something missing there. And if that's there, because if you think about speech, equilibrium, and sensory, all 3 of those things can tie into inner ear, outer ear issues. So that was kind of our first thing. We said, yeah, that'd be a good thing to do. A couple other things. I know they tried weighted
Hey,
vests.
Kurt, can we throw in ENT as well? I think he should see both. Okay.
That
thank-
was one they came up with too, was an EMT. So yeah. They also came up, said something about with regard to water play or being in water for water therapy, because anytime you have hyposensitive proprioception, you can't tell you're falling until you're already halfway there. That water gives you a little bit more proprioception. Plus there's that little bit of weight that the water gives to that may be kind of comforting to him. Another one that was kind of appropriate for right now is with him getting, if he's got siblings that are going back to school, maybe getting him his backpack and you put some of his kind of heavier toys in there to give him that little bit of weight that can help with that proprioception down through the joints and the joint receptors there. So we had a bunch of others too, but there was having a small space, a cozy corner, a tent in his room, even a cardboard box, put him in. I told the story of my daughter who never would sleep until Christmas time. We took the Christmas tree out of the box and put it up, and she started sleeping in the box and slept great for 3 weeks. And then my wife says, time to put the tree away. We got to put it in the box. I said, no, we're going to put it in the bag. And we let her keep sleeping in the box for another 3 or 4 weeks. And she started sleeping better. So sometimes just easy things like cardboard boxes, those tight spaces can be real beneficial for kids. So anyways, I sent those over to Bailey. So some real good suggestions out of our group as well. We did have the question though, that we'd love to know, why did he not get naloxone until 2 weeks after the NICU? And I mean, there wasn't any information. Obviously, it's not Bailey's kid, so she can't give us information, but it just seemed odd that they would wait 2 weeks. There had to have been some reason. So we're just curious about that reason, if we ever figured that out.
Well, there you go. That's a great reason. I mean, a great question that we could pose back to it. Well, I appreciate everybody joining and sharing your information. Great resources. They will be posted on our Canvas page. So if you want to go and make sure you have all those resources, please locate that. And then our next session will be in September. I'm in tears saying September. But we will be having Trisha Reynolds share with us about information on incarcerated mothers and how they're working to support the family system in that area. So I think everybody enjoy the rest of your Wednesday afternoon, and we will talk to you guys all soon. Thank you.